All right, let's talk about this review sheet for upper extremity 2. When we go through the anatomy, you guys recognize those anatomic structures. You should, at this point, you should have identified those structures on dry bones, on the anatomage and radiographically. You need to see those on all of those different things. You need to be spinning them and looking at them so that you have accurate 3D models of those structures. All right, but let's get to the questions in the anatomy. It says, number 1, what's the common site fracture of the humerus? The common site is the surgical neck. It's the surgical neck because it breaks often. The other neck, as a side note, the other neck is the anatomic neck. The anatomic neck sits directly below the humeral head. The surgical neck is distal to both of the tubercles really in the head. All right, be able to identify that. Scapular process is more superior. Which one? The acromion is more superior. The clavicle swoops superiorly and articulates with the acromion. The acromion is more superior than the coracoid. What lies between the two tubercles? Well, that is the intertubercular groove wherein the biceps tendon can come up and attach. Number 4, the articulations within the shoulder girdle. Well, there's only 2 bones in the shoulder girdle. So that is the scapula and the clavicle. Now, the clavicle articulates with the scapula at the acromion. That is the acromioclavicular joint, the AC joint. Additionally, there is the scapulohumeral or the glenohumeral joint. It's not really shoulder girdle per se because the humerus is not a part of that, but you may want to be familiar with that. Moving on from the questions related to the anatomy, let's move into the projections and some of the positioning and evaluation. All right, so we have these projections. There's the humerus, the shoulder. There's a couple variations of the shoulder, one being all the AP rotations. There's 3. There's the Y view, the Gracie, the Lawrence, and the Fisk. Beyond that, there's the clavicle, the scapula, and the AC joints. So it really isn't a ton of information. I know it may feel that way, but it's not a lot if you organize it appropriately. Let's talk through the positioning for each of these very, very quickly, okay? Now, let's look at the humerus. There are 2 projections in the humerus series, the AP and the lateral. The AP is positioned upright supine, however the patient comes in, that's how you do it. It's 14 by 17 lengthwise. Remember, we're angling the tube for this. Make sure you watch that video. We're centered mid-humerus. For the AP, they're in anatomic position, the palm facing forward. For the lateral, the back of the hand goes on the hip, and it's basically centered the same. Take the picture. Bam. That's the AP and lateral. The shoulder. For the AP rotations, again, we are going to position them however they come in. We are going to center 1 inch below the coracoid process. These are AP, so the patient's back is up against whatever the bucky or the upright bucky are on the table. Doesn't matter. For the AP projections, we center 1 inch below the coracoid process. That's it. All right. For the external, the hand is anatomic position, palm forward. For the neutral, the palm is on the leg. And for the internal, the back of the hand, again, is on the thigh. Very straightforward, very simple. We don't change the centering. That changes the anatomic presentation on a radiograph, so it looks quite a bit different, and we'll talk about that in a moment. For the AP oblique Y view, remember, we can do it AP or we can do it PA, but the AP oblique Y view that is part of the shoulder series is positioned 45 to 60 degrees oblique, and we are imaging the side away from the bucky, the elevated side, okay? So if I'm doing the left shoulder, the patient is in an RPO. That's for the AP projection, okay? Just make sure you understand that. 45 to 60 degrees oblique, we're gonna center it right on the humeral head, or on the glenoid. There we go, don't clip the scapula, that's our Y view. The goal is to superimpose the humerus directly over the true lateral position scapula. All right, so the humeral head will appear at the junction of the coracoid process and the acromial process. Where those 2 meet, that will be the glenoid, and the humeral head should be right there when appropriately positioned. All right, moving on. Let's talk about the AP oblique for the Gracie. It's another AP oblique, but on this AP, we are imaging the side down. For the Gracie, the goal is to demonstrate the glenoid fossa. all right? We want to see that joint wide open. The way we perform it is the patient is in whatever position they're in, upright or otherwise, and we rotate that patient 35 to 45 degrees towards the affected side, meaning we are imaging the side down, okay? We center 2 inches medial and 2 inches inferior, so that is 2 inches in, 2 inches down from the superolateral border of the shoulder, the highest and most lateral point of that patient's shoulder. That'll put you directly on the glenoid. We shoot our x-ray. These so far have all been shot on suspended respiration. No special instructions, just hold your breath. For the infero-superior axial projection, or the Lawrence method, all you need to know is you need to be able to identify that on a radiograph and label all the appropriate anatomy. There are many ways to perform this one, and we will work on that. You will see it at clinics. For now, all I need you to know is what I've said, okay? The Fisk modification is of the intertubercular groove. Again, be able to recognize it and know what we're looking for. As far as performing it, that'll come later, okay? All right, moving to the clavicle now. For the clavicle, there are 2 projections. There's the AP, and then there's the AP axial clavicle projection. For the AP is very, very simple. We are crosswise with a 10 by 12, or we'll collimate our field into such on our large DR plate. We will center mid-clavicle and use a perpendicular beam. Don't clip the SC joint, don't clip the AC joint. That's your AP clavicle. For the AP axial, you're also mid-clavicle. However, for this one, we make a central ray angle of 15 to 30 degrees cephalic for the AP projection, okay? Now, that is based on patient size, really. For patients who are larger, thicker from front to back, we will utilize a smaller angle. For very small and narrow patients, we will use the higher angle. Some facilities, however, will have a set angle for every patient. Just recognize the thinking behind why we adjust our angles and act accordingly. That is the clavicle. Moving to the scapula. Now, the scapula is really 2 projections, but there are 2 variants of the lateral. First, let's discuss the AP. The AP scapula is performed with the patient in whatever position, upright or supine. They are to abduct their arm away from their body 90 degrees and bend the elbow so that the hand is facing up, palm forward. At that point, we center 2 inches below the coracoid process. Hold your breath, beep. That's it. 2 inches below the coracoid process for the AP scapula. For the lateral scapula, we take the patient's arm of interest. We oblique them the same as we do for the Y view, 45 to 60 degrees. But this time we take the arm of interest and we bring it across the opposite shoulder or place that forearm on the head. That's going to give us a lateral scapula that demonstrates the body. If we are looking at the acromial and coracoid processes, however, we place the back of the hand on the posterior thorax and flex the arm forward. That will demonstrate those 2 processes. Those are both for a lateral scapula. Okay, either way, the humerus will not be superimposed over the scapular body, though. All right. Finally, we have the AC joints. The AC joints are the only projection performed at 72 inches. Also, we will use the 14 by 17 crosswise for this one. This is performed with and without weights. Essentially, we place our central ray at the sternal notch, which should put our beams crossing through the AC joints. That's what we want, all right? This is a bilateral projection. We do it without weight first, and then with weights and compare the 2. Those weights are placed on the wrists, not the hands, and then they're told to slide to the floors, not to injure the patient when they release them. That is your, that's the projections right there. So let's go to the evaluation questions, though. 14, 15, and 16 all tell the same story. They're just me putting those out there. So what I want you to be able to do is to discuss how the epicondyles look on every shoulder rotation, connect that with how the tubercles appear, and connect that to how the hand is placed. So let me talk you through what I'm saying here. First, we'll talk about the AP shoulder and external rotation. For that, the humeral epicondyles are parallel to the IR. okay? The tubercles show up with the greater tubercle in profile laterally and the lesser tubercle superimposed over the humeral head. That's all I need you to talk about, okay? Oh, and palm forward, forgive me. So that's the three structures connected. Let's go to the neutral. For the neutral projection, the humeral epicondyles are 45 degrees to the IR. Both tubercles are partially superimposed over the humeral head, and the hand is placed flat on the thigh. For the final projection, the internal rotation of the AP shoulder, the lesser tubercle is in profile medially, and the greater tubercle is fully superimposed over the humeral head. The humeral epicondyles are perpendicular to the IR, and the back of the hand is placed on the leg. So that's how all of those connect, okay? And I need you to understand that. Number 17, why is a scapular Y performed? Within a shoulder series, we perform a scapular Y to demonstrate anterior or posterior dislocation. Number 18, what positions are patients in for shoulder humerus studies? And how are they often performed and why? The patient is imaged how they present. They come in laying down, we do them laying down. If they walk in, we do them upright, standing. We don't want to alter their position in terms of laying to standing or standing to laying, okay? Number 19, the purpose of the Gracie method is to demonstrate the glenoid. That's it. The Fisk modification shows the intertubercular groove. That's it. Or fractures of the tubercles as well. What is the name of the reaction that people have when they clench and increase intrathoracic pressure? Number 21, vasovagal reaction. That is a vasovagal reaction. It's compression of the vagus nerve causing them to faint. Number 22, make sure you recognize the positioning diagrams. So for all of these, you should be able to look at an image, like a drawn up image, and say, oh yeah, that's such and such projection, okay? Number 23, AP oblique projections. Are we demonstrating the side away or the side down? How about PA? All right, so let's talk through that's only for the obliques, okay? So if we talk through the two obliques we have, really we only have two. We have a Y view and we have a gray sheet. For the AP Y view, we're doing the side away. For the AP gray sheet, we're doing the side down. Now with a full understanding of the anatomy, that should be easy to apply, okay? So make sure as you position these things, you're picturing what happens to the anatomy so we can walk up Bloom's taxonomy and have a deeper understanding of the knowledge, okay? Now, if we were to flip that, the PA is just the inversion of the AP. For a PA oblique scapular Y, we're now imaging the side down, the opposite of the AP. And if for some reason somebody wanted to do a gray sheet PA, which should never happen, but if they wanted to, they would perform that by imaging the side away, okay? Because it's the inversion of the other. All right, so that's basically it. Make sure you take time looking at these images. Hopefully this helps clarify a couple things. Make sure you see me if you have questions.